to this unfortunate but memorable day in history. Today's presentation, we're going to be dealing with anxiety disorders. As a little bit of history, if you remember from 2013 in DSM, we delinked post-traumatic stress disorder, actually way back as well, from these fear-based anxiety disorders. So today we're going to be talking about fear-based anxiety disorders in children and adolescents, and maybe youth if you want, and especially as it pertains to pediatric primary care, with a very focused and targeted approach, not only assessment, but also a review of interventions. And the interventions will focus primarily on pharmacologic, and we can talk about non-pharmacologic interventions, but it goes beyond the scope of this presentation today. Thank you. These are your objectives, and as I said, it will be a focused review, and as we go through, you'll let me know. Speak up. I seem to have lost the panel participant screen on my Teams channel here. My staff here, we all voted, and they voted that we're going to transition everything to Teams. I don't tend to use Teams, but here we are. So just speak up because I do not see folks. So here we go. Please.
Focus on training.
Yep.
The volume.
You got it?
Yes.
All right. Then let's move it on. Right. So what do we know about anxiety? Oops. Can somebody please mute their... Hello? So what do we know about anxiety? Anxiety is extremely common in today's society. When we look at the epidemiology of youth, and am I still up? Yeah. We know that anxiety disorders are common. The single most common disorder is major depressive disorder, but when you combine the three major fear-based anxiety disorder, generalized anxiety disorder, social anxiety disorder, and separation anxiety disorder, they as a group are much, much more common than depression. So we see a lot of anxiety, and we not only see a lot of anxiety, but we see anxiety disorders, right? Then, as you can see, anxiety is a spectrum, right? And we all have our things, I always say, in all of the sessions and all the appointments with patients and their families. But not all anxiety is clinical, right? And so if some of you have seen these presentations before, in a very crude way, what makes anxiety clinical? Well, the two big domains is how severe are the symptoms and how much impairment are they resulting in, right? So why? Because I could have anxiety, but if I'm functioning, if I'm sleeping well, if I'm eating okay, if I'm socializing appropriately, if I'm focusing at work, and et cetera, then, hey, join the crowd, right? This is how it works. But the more severe those symptoms start becoming, and they start interfering with one or more domains of functioning, whether it's, as you just heard it, right? It could be physical, it could be social, it could be academic functioning, if you're a little bit older, occupational functioning, on and on and on. Then we start considering that spectrum moves on into something more clinical. And what is clinical? Something that is a need of intervention or treatment. Hence the focus today, right? And the four main ones, and really the big three we're going to talk about, are GAD, social anxiety disorder, separation anxiety disorder. We formerly used to think that this was only a childhood-based disorder, and now in our latest iteration of our nomenclature, we moved it into anxiety disorders and delinked it from just a child disorder only, and panic disorder. Many years ago, we used to think that panic disorder did not exist in kids. Kids could not have panic. They could not have panic disorder. And now we recognize, although it is much less common, that panic disorder can present in pre-adolescent children as well. And we're clustering these because they tend to have similar characteristics, and we will not be reviewing the DSM criteria for that. You all have your references or can look it up on dsm5.org or psychiatry.org and just go through all your criteria, or your electronic health records have it. But just that roughly to talk about the commonalities as far as practical everyday symptoms. Then the first are physical or somatic. So when you do your review of systems, you can go by system and say cardiovascular. Yes, palpitations and even an increase, or benign or not, in blood pressure. Respiratory problems, moving air or hyperventilating. Gastrointestinal, I gotta run to the bathroom, I'm gonna throw up, I feel nauseous, etc. Muscular, I feel very tense, and that's why I joke, as you get older we get our massages, right? Because that helps us with some of that, at least temporarily. On and on and on in any system. But as with any major emotions, being the anxiety, right, or the extreme anxiety or the apprehension, comes these changes, these distortions in thinking. Then the basic ones include things like anticipatory anxiety. So anticipatory anxiety is worrying about something before it's happened. And if you know about CBT and other therapies, the trigger statement is the what ifs, right? But what if the elevator gets stuck? And what if I go? And what if I mess up my presentation? And it's like, oh my gosh, it's the opposite of, it's kind of on the other end of the spectrum of mindfulness, right? About not being in the moment because you're worrying about something that hasn't happened. And there's a really good chance it won't happen, right? Oh, we didn't get stuck in the elevator. We're here already. All that worrying and that anticipatory worrying and look, right? Then that is frequently associated with catastrophic thinking, right? And the trigger statement frequently, remember, not always, frequently are the, oh my God, it's like, and oh my God, if we stuck in the elevator, and oh my God, and if I mess up, and oh my God, no one's going to think, and oh my God, and in the moment, right? And so things that are this small get magnified very, very much so, to where the person frequently gets overwhelmed, right? If the anxiety is severe enough and can really kind of shut one down, right? So why? Because these are things that individuals look at if you're going to be doing therapy, right? And especially in CBT, you would want to journal it and track it. Then that's also associated with ADS, right? Automatic negative thoughts. So if a youngster doesn't like presenting, has social anxiety, the performance subtype kind of, and doesn't like presenting in front of class and said, okay, come and I want you to come right now and present in front of the auditorium, 300 kids. The first response will be negative, and it'll frequently be, they won't be neutral or even positive. It'll frequently just no but. When I call it the no buts, but it could be any other trigger statement inside that. But wait, no way. I've had some just say absolutely no without blinking, right? And that's why it's automatic, right? Those thoughts are kind of programmed in the brain, and as you all know, right? They tend to be very inhibitory and impairing, right? The fourth is ruminations, right? And ruminations is different than it's a little bit different mechanism than an obsession, where one obsesses over things and ruminates over it and goes over and over. Yeah, but what if I got? Yeah, but what if I mess up? Yeah, but what if no one's there? What if I go to that party and they don't like? Yeah, but what if I have to get on the plane? And yeah, but what if on and on, right? So these are these cognitive distortions, changes that are very typical. They're not owned by anxiety, but very typical of these fear-based anxiety disorders, along with these physical and autonomic kind of symptoms as well. And then the last one's avoidance, right? And avoidance is part of the impairment. It can be adapted at times, right? So if I have this big fear of driving down I-95, I may take the side roads and get to where I'm going, and therefore I may not necessarily be as impaired. But at some point, we don't want the anxiety to drive all the decisions, right? We want to be able to say, we got it, I'm on there, I'm driving, or no, I don't want to go on I-95 today. I'm tired, or there's too much traffic, or there's an accident, and I am making that decision and not letting the anxiety drive that. Or I had one mom in my previous life who who had anxiety, and the office was on the 10th floor, and so she would avoid the elevator and then come up each time. Sorry, I'm trying to get back to my screen here because my camera keeps falling. And so avoidance can be adaptive in the short run, but in the long run, no. Well, you all don't need to see me, right? So we'll leave that the way it is. I take it my screen's not up now. I am so sorry.
Dan, your screen is up, but we see all the slides, not just the one you're
I
talking
know.
about.
That's
Yeah.
why I'm trying to get back to
Oh,
it. Thank
okay.
you very much. I really appreciate it. Yeah, I was joking earlier. We think after 4 years I would have mastered it, but since I'm a Zoom master, but not a Teams master. So we will go back to Teams remedial training immediately after this. So those are your basic cluster of symptoms that you see with anxiety, right? And you should be reviewing for that and screening. One of the things and if your electronic health record has it, that's great, is using your GAD questionnaire. Now, we know it only screens for GAD and in adolescents, but it can be used as a little bit of a proxy for the other disorders, but it's not specific for it, but it's a good screening questionnaire, and it's really expeditious. It could be answered real quickly and scored very quickly. There are thresholds, right? It doesn't make your diagnosis, but it creates thresholds as far as severity. Then severity to help guide you in when you should be looking more, whether yourselves or someone else to be looking at that, right? And so the GAD is a good, relatively quick form, especially in high volume settings and which focus on adolescent health, right? And then the other kind of form questionnaire that we recommend that's in the public domain is the SCARED, right? The Screen for Child and Adolescent for Child Anxiety Related Disorders, and that's a parent completed version. It's a little bit longer. It takes a little bit more time. Then the scoring, if it's not automated, can be a tiny bit more complex, but it's a really good form that's pretty comprehensive to help screen for anxiety disorders and the specific types of school-based anxiety, not school-based, this fear-based anxiety disorder. So please keep it in mind. If you're not already using it, either of these forms have their place for screenings and helping you in your workflow and your respective practices, right? So we talk a lot about this, that chronic anxiety, whether it's trait anxiety or actually clinical anxiety, is managed and not fixed, right? That we talk about, you'll see in the anxiety world, we talk a lot about mastery. I've got to get a handle on it, right? It's not going to be zero anxiety, but I got a handle on it. Okay, I got it. I'm in the elevator. I may be a little bit anxious, but I got it. It's not impairing me. It's not overwhelmingly severe anxiety. I've got it and I'm there. I've practiced. I'm on the airplane. I'm on 995 driving. I've got it. I'm a little bit anxious. I'm kind of anxious, but I'm driving and I've mastered it, and I am now functioning and managing it, and I am doing what I want to do and not letting the anxiety dictate what I should do necessarily, right? Or always. Back to deciding, anybody who uses their their GAD-7, right? The quick and easy kind of decision tree, right? That if you have your threshold, not that no further actions needed if the GAD score is less than 10, but that you don't necessarily, you can do further screening questions, especially if you question the reliability of the information, but that if it hits that threshold of 10, of moderate or above, that you should really explore that further, right? And that you should really assess that further, either vis-a-vis your own assessment or referral. Then that focus assessment, well, it's a lot of different factors, and some of it depends on your relationship with that individual. And in a little bit, we're going to focus on teens, but it could be pre-adolescent youth as well. Why? Because your strategies are going to be different, right? And if you know the youngster better, you have some kind of relationship or rapport, you can get right into it, as opposed to having to tear yourself into that. And that could be time intensive, right? Like identifying, like, oh, we're so glad you're this, we're so glad you see the need, and other strengths, especially how they have managed anxiety or other situations prior, right, in the past. Depending on the individual, how much anxiety and how much overwhelming, especially they are in that cross-sectional appointment, you may need to keep it very here and now focused. But what if in the future, because that person may have all of those distortions pretty programmed in there and pretty stuck on that, right? So you need to be not only supportive, but non-judgmental in your assessment now of those things, right? And sometimes it can be really, really clear when you start asking about, like, hey, how often do you ask yourself, what if, right? Oh yeah, da 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 da. Then if there are certain triggers, as opposed to GAD, right? Like either in social and separation issues, like, and what happens when your mom goes out, and what do you think when she doesn't answer your text within 2 minutes or 30 seconds, etc. And so again, with a focused, targeted questioning, but also be reflective and listening, and pause and provide some concerns. It sounds like, this has gotten pretty severe or pretty bad, like we say sometime colloquially, and it sounds like we need to be doing something about it, right? And then along with that comes assessing the impairment and the risks, if you will, right? Then this is the feelings thermometer, or what's been called, or more technically, the subjective units of distress scale, the SUDS. Used a lot in depression, can be used in anxiety as well. And it's meant to provide a little bit of a thermometer, barometer to gauge subjectively what the individual is experiencing. You do want to keep it time limited, right? Because if you're trying to summarize it over the past year, it's very hard to kind of summarize numbers, but it can provide some estimates as to how the individual's feeling, even if it means a lot of variation, but that's another barometer, if you will, how they're feeling, as opposed to, no, I've been really 90 out of something, et cetera, et cetera. If someone says they're feeling 100 all the time, I always say you're usually lying, right? Like, hey, we all have our things, right? But to have it, to always be feeling the best is usually a deep breath and say, okay, you're going to make me work here. Let's go over this a little bit more, if you will, right? And so that's a start. And then from there, you can get into more of the qualitative, descriptive things like, oh my gosh, and when you're feeling, if 100's the best you felt, and 0's the worst, right? You can get into something more descriptive, right? Because especially with teens, it's not binary. It's not so black and white. Say, well, I'm only anxious. No, I could be anxious and angry, or I can be sad and mad. I can be anxious and sad. And it's our jobs to kind of tease that out descriptively, if you will. And so therefore, you want to be very cautious, depending, if you're going to use multiple questions and tier it in, you could start in this more black and white setting, but that you want to be very cautious about reducing. Well, are you happy or sad? I said, well, gee, is that the only options? Maybe I'm a little bit both, or maybe I'm neither, or maybe I'm nervous, I'm sad, I'm upset, I am angry. It's a mixture of emotions. So please keep that in mind as you're going through, that it's not so black and white all the time, right? It may help us get through our interviews, but it may not provide useful information. And actually, it may, even provide information that leads us up a not best path, right? And then what do we know? Well, remember, suicidal risk, suicidal thinking, and suicide is not owned by depression. And so, yes, there is a lot of evidence that anxiety is also involved in suicidal risk. And so we do need to be taking that into account. And I didn't put up this whole paradigm I put about how to help assessing in teens because I thought it was a little bit too much for this setting, right? But that especially in that acute anxiety state, remember what we said, and if you know anybody who's experienced a panic attack, those cognitive distortions, the thinking changes so much in that moment that sometimes those discrete periods of intense anxiety can be where the risk is. And then if you see them in the office a while later, they may not present that risk any further because they're thinking more clearly in a more linear way. And so you really want to take them back to that moment to say, oh my gosh, and when you were feeling that anxious, how were you thinking? Were you thinking about killing yourself or ending your life in that moment? And I usually preface it by saying, you look pretty calm now, right? But let's go back in that moment, right? And then if, depending on their responses, you can probe or assess further. And then lastly, factor in your impression or that proverbial gut feeling in that, right? Because a youngster may be denying it completely, right? But you have collateral information. Oh yes, they were talking about killing themselves and they grabbed the knife and then they went and did this. But that if your gut impression, you factor that in, right? It may not, it's one of the variables now we tend to take into account. It's not the only reason, right? But not the only factor, but you should take that into account, right? And focus on the moment, right? Like especially during that visit. Okay, what are the risks right now? There may be some chronicity to it, right? That if there's another panic attack or acute anxiety, that individual may be at risk, but the more proximal, the more imminent risk may be less so. So point being, assess for suicidal risk even with anxiety as well. So please do. So the person's come to the office, you've done your screening, they've completed their screening questionnaires, you've reviewed them, you've done a little bit more probing and assessing for that anxiety and how many yeah buts or how often you go like, oh my gods, and how long has this been going on and how severe is it and how impairing is it. Then when you get to your medical decision making, right, as you do in any, I'm assuming, outpatient visit, an E&M visit or follow-up visit, and you're considering medications or you are not considering, but you should ask yourself, does the youngster have an anxiety disorder? Now you notice I'm talking about anxiety disorder and not anxiety, right? So does the younger have an anxiety disorder? Okay, then what about the severity of it? Because if it's minimal, all right. If it's mild, we generally don't consider medications. Once it starts becoming more moderate to severe, then we start entertaining the potential use of medication. And then the flip side of that, as we've mentioned before, if not, you'll see that this has been a little bit of a highlight of today, is how much impairment has that been associated with. So even if the youngster has some moderate anxiety, but they seem to be functioning fairly well still, then you may or may not, in your clinical estimation, think that medications are indicated, right? And there it says depression, but it should be anxiety, right? And not only how much do I believe, but how about the family? Okay, So let's use a little bit of vignette to kind of illustrate, right? And there'll be another one at the end. Maria is 17 years old, presents for her mother for an urgent outpatient appointment. Over the past 3 weeks, have been extremely anxious, not just anxious, extremely anxious, sleeping only about 2 to 3 hours a night, and began refusing to go to school. Needless to say, she's falling behind in her schoolwork. Then she has exhibited these new onset panic attacks, did not have them before, averaging about 4 a day over the last 10 days. Her mom describes her as, she's always been nervous though, but this is worse, right? These are new, and no evidence of mania, depression, or psychosis is evident. There's a strong family history on the maternal side of having anxiety disorders. And then the question arises about, should one start medications? I'm going to loop out of this for a second so I can see. Any quick thoughts, any brief thoughts? I know this is always a challenge on online, but any thoughts on this?
I think more thorough interview before the medication is probably a good starting point. More often than not, especially as a pediatrician, I find that parents come into the office with the mindset that they're going to leave with the medication. So having a little bit more conversation about context and what had led up to this point would probably be how I would approach it.
That's right. So the same thing, right? You want to get more information to see if, take your pick, she has an anxiety disorder, and what is the general severity of those symptoms and how impairing it is. And can you use a tiered approach, right? Okay, let's make a referral for psychotherapy, and then we'll get you started. We'll get you an appointment in 6 days, and then that individual's going to start their assessment, and then they're going to start therapy. And again, these are just illustrative scenarios, as opposed to someone's already been in treatment and it's been engaged in true cognitive behavioral therapy, and then they're still anxious, and that may impact your decision as to whether utilize medications or not. So yes, it's meant to be illustrative, right? But just to look at the impairment of things, because if someone was starting therapy de novo and was this impaired, there's a chance that the symptoms would not improve in the more immediate future, and it may impact the decision or not for medication. Remember, the mantra is the appropriate use of medications. We don't look to over-medicate, but we also don't look to under-medicate, and we look for that famous Goldilocks kind of guiding principle to see what's just appropriate for that use. So yes, more information is extremely useful as well, right? So very good. Again, it's meant to be illustrative. It's meant to be provocative, to have you think about these things, which you do anyway, but at least to be thinking about these things, right? This is a big one because obviously we found it out not only in the collaborative, but we know that already is that people, and we know that in the literature, even in other areas, whether it's HIV meds or not, that big issue is not only skills, but comfort, right? It's not only skills, but comfort. And oh, yes, that's great. I know what I have to do, but I don't feel comfortable, right? And we know that this exists, right? We have a lot of real-time experience. And it's not only here in Florida, but it's a national phenomenon. And it's been eminently clear that, right, education, you can work on all the education and all the skills you want, training, but that in and of itself is not enough. And that prescribers need to feel not only motivated, like, hey, yes, I want to do this, but they need to feel more comfortable with the decisions, right? Then a lot of it has to do with honest self-reflection, right? Because in speaking with certain prescribers and pediatricians, a lot of them go, yeah, but no, I'm not. And it's very automatic, right? They're going to say no right away. And one of the things that has come up not infrequently has been the concern about risk and lawsuits. Yeah, but I know, but what if But it's like, oh, here we go. Yeah, but what if I get sued? And what if this one negative outcome happens, etc.? And I have my responses, but I won't script them out for you here. But that's not unusual. And so that's usually leads to something that sounds ever so obvious, right? That if someone is going along in their career and they don't want to prescribe medications for anxiety and don't have a desire, and they're kind of adamant about it, they're not going to. They probably won't, right? On the flip side, if someone says, yes, gosh, I know I don't have a lot of experience, but maybe I can see how I can best do that, then yes, that's an opening. But clearly, as with any behavior, if someone doesn't want to, it will not happen, right? The families, well, we know the families want it, right? That families prefer their treatment by their pediatricians, right? And especially with an engaged and trusting relationship, they are kind of more wary of being referred to a specialist or quote unquote passed on, right? And that and we know all these things, right? And we've learned from the collaborative, right, that just making a referral is usually not enough, especially families that come in with those attitudes, right, or those perspectives, and that attendance, just going to an appointment with a child and adolescent psychiatrist is a good start, but not enough, because an attendance is a proxy for participation, right? I could attend, but I didn't say a thing, or I'm not going to really participate in treatment, right? So attendance is a good start. Then you want participation, but what you really want is engagement, right? True engagement in the treatment, right? Whether it's psychotherapy or whether it's medications or something else. So just merely going to an appointment is an okay start, but it's not enough. And that's why it's important. And if you look at the collaborative, that it was learned that it's important to know these things up front, because maybe the protocol be a little bit different if they're reluctant to engage rather than someone who's very open to kind of go to a specialist for care and treatment, right? And so what really seems to help, right? Well, one is not only having your referral networks and good collaborative relationships with local mental health providers, but the availability and the use of the consult services, and whether it's telehealth or phone consult services, that really seems to help to have that available to say, okay, I'm going to start this, but I have these backups and other services available for me. And what also really helps bring down the concern or worry about starting to prescribe these medications is a couple of things, or four things, right? One is just focus on a few things that you can do. Not the exotic things and not the one exception out of 1,000, and try to master and do the simple things first, right? Before you move on, like with any learning or training objectives, you want to be able to master this hierarchy of objectives before you move on to the exotic and the complicated things, right? And then you start with the basic interventions, right? Get comfortable with a couple medications maybe and say, okay, I'm going to start this. And then if this and this and this doesn't work out, that's my threshold for referral. But I don't want to learn every single medication or combinations of polypharmacy, right? That should be another flag. Oh, I'm up to 4 medications. Maybe that's an indication about the complexity and the complicatedness of it. And then, like always, as you know, you start low and then you go slow. So yes, one of the takeaway points is get comfortable with the most evidence-based, put it as tested medications, evidence-based medications, and begin with those first, because that will help you master things and help you look at outcomes and hopefully also get better outcomes. And then, yes, if you're going to do that, then the two other variables we know is that you have to prescribe an adequate dose, because again, just starting a medication and maintaining it at a suboptimal dose will not lead to a great outcome, right? Even though you may say, I'm doing it. Then secondly is, not only the dose, but the time, right? That the individual needs to be treated with an adequate dose for a long enough period of time. And we'll get back to that in a second as well. Basic things we know about these medications. Adapted right here from your USF best practices guidelines. And a shout out to Marie and Sabrina and the team for all their hard work in developing these. But this is what I used to call the bottom line, right? Was taking these very elegant guidelines and reducing them to one slide for you, and that the two medications that you begin with, that they're based on the greatest strength of the evidence, are sertraline and Zoloft, or fluoxetine and Prozac. And they're both on level 1 because you could pick one or the other. And they're both off label, right? They're not FDA approved for that. And why is that? Well, because all those studies came out afterwards, after they went generic, right? So that there is fair amount of robust evidence to demonstrate that they should be first-line medications for children and adolescents. Keep in mind, what works in adults may not be beneficial in teens, right? So you begin with one medication, monotherapy with one, and you start low, and then you start titrating up until you get improvement of your target symptoms or there's intolerable side effects. That if there happens to be a poor or non-response or intolerable side effects, then you can see on level 2, then you switch it over to the other one not used. Again, monotherapy, right? And you go through that same process again, right? And then if you need to get to a third iteration, you can decide whether you want to reassess or refer, which you should either at the very least reassess if they've gone through two trials, 2 iterations of monotherapy with one of those two, with those medicines, or whether you want to move on to duloxetine Cymbalta, which is FDA approved for GAD only in youth, right? But the evidence base is less strong actually when you look at it compared to sertraline and fluoxetine. Or as we just mentioned, you said, gosh, I've tried 2 of these already, and this didn't seem to help. It's time for me to connect this child with a specialist. Let's go, get them going. And that's great. That's how it works, right? For all of us, right? When do we seek further contact and referral? There's a full table on your right, so you have it. It's online at their website. If you have those wonderful booklets, it's in there as well in more detail. And then keep in mind, if you're trying one iteration of one, I'm going to start sertraline and I'm titrating up and there's intolerable side effects, etc. We typically don't recommend doing it sequentially. That means let me wean you off completely this medicine and get you off, and then I'm going to start the next one. That if you still believe that they have an anxiety disorder of sufficient severity and or impairment, and of which medications are indicated, you want to cross taper, right? You start weaning down one, and then you start introducing slowly the other, so that the medication starts moving from, you start dosing from one to the other and increasing it. So we don't do it sequentially. And you've heard, right? Monotherapy first. Depending on the setting, depending on the severity, you could titrate it once a week. You could go slower depending on the amount of impairment and how, and the clinical indication for that particular youth, right? So think about it and how you want to titrate it up, right? Whether it's a full month or maybe less, depending on the severity of the symptoms, right? How long should they be taken? The rough guide for first episode and no comorbidities is 6 to 9 months after the appropriate dose has been reached and there if you improvement of those target symptoms. But we know that if there's comorbidities, like there's presence of more than one anxiety disorder, or if there's a major depression and a comorbid anxiety disorder, it'll usually be longer. Yes, it will. And these are important things to go over with the youngster and the family. Why? Because we know the presence of comorbidity tends to bring differences in response, and we know that typically one of the disorders responds more robustly than the other, and you want to be clear, right? And you want to be careful, especially with depression, right? Because we've learned that, especially with DSM-5 coming out, about what we call artificial comorbidities, right? That anxiety can be integral or part of the depression, right? Or it could be a separate disorder, right? Because there was a fair amount of literature talking about this artificial, oh, you've got a major depressive disorder and a generalized anxiety disorder, whereas if you look at it, the anxiety really developed along with the depression, and the history and the information doesn't seem to support that they're separate disorders. And therefore, your expectation on treatment and prognosis and other things may be a little bit different as opposed to two comorbid disorders. So if you have both, then you have typically to assess which one of the two disorders is most impairing, right? And then from there, you develop your hierarchy and your treatment priorities to say, we're going to treat this first, right? Because it's very hard to say the shotgun approach, we're going to treat everything at once, right? And these are the things that predict how robustly, right? So if an individual like Maria and that first, who's been anxious her whole life, have a lot of this kind of trait anxiety, if you will, this subsyndromal anxiety, and then develops a full-blown anxiety disorder, is going to have a different response than a youngster. If Maria was pretty clean, pre-morbid, had pretty good emotional functioning, and developed all these symptoms, new onset in the last 3 or 4 weeks, the response to medication may be better or stronger or quicker, if you will, right? And so, and then the last one you'll see is that latency period, right? Like, oh yes, I've had this moderate to severe anxiety for 9 months now. It's different than I've developed these symptoms over the last 3 weeks only. And if the decision is to start meds, you would expect a little bit more robust response. Now, how do these things play out in the real world? Well, the important part is that you're setting realistic expectations, right? Because if Maria's been anxious her whole life and now developed this acute anxiety, the response may be different than if Maria was pretty clean and just developed this anxiety now. Or the presence of depression and anxiety, you want to be clear on the expectations of treatment response, how fast, how quick, and how robust the response may be. What about antidepressants and suicidal behaviors? Well, yes, this warning still exists, formerly known as a black box warning. Now it's a box warning. And why? Because it's the highest level warning by the FDA, alerting individuals as to the potential risks with medications in general, right? In this case, we're just highlighting fluoxetine, Prozac. Even though all the subsequent studies, with the exception of venlafaxine, but generally all the studies since the FDA initiated these warnings have not shown that association. The warning still exists, and you do want to have care when you start an antidepressant. It's class specific. It's across all of them, right? And the potential increase of pre-existing or new onset suicidal thinking and behaviors. And you need to really have that discussion with the families, right? And we think things like, being activated, like overly stimulated with these meds, are some risk factors for that. So please keep that in mind, right? And then needless to say, you probably want to document. All righty. So take that little box off. And I'm leaving time for questions and discussion, right? So let's talk about Katie. This happens a lot. my son's a pediatrician, right? But God bless you all in pediatrics and primary care, right? So Katie, so you get a call on Sunday at 11:45 at night that 12-year-old Katie is really panicking, right? Extremely anxious and even agitated, right? And not going to sleep, right? This, guess what? The school year begins the next day, first day of class, and Katie's going to a new school where she says, I don't know, and I don't know anybody, and I don't know. And the parent pages you and asking you to call in meds and to help with their anxiety, right? And remember, it's about midnight now. And how would you proceed then? Again, these are meant to be illustrative, provocative, as a basis for discussion. It's not so black and white, but any thoughts? Anybody ever been a parent at 11:45 at night and then there's some freaking out at home? So the parents are looking for something, right? Like, what do I do? Oh, we're going to make a referral for therapy. Oh, okay. What do I do tonight? Right? No, just hang in there. Oh, remember? We've all scripted this, right? We've all lived this in the past. Any thoughts?
I think this is, I mean, I will speak from my own experience as a pediatrician, is that, it doesn't, at least for me, it doesn't come up this way often. It's more so the somatic presentation of anxiety that tends to cause the late night call, so to speak. I think I would handle this depending on how well I know the patient. If this is someone that we've worked with for, let's say, a while, and I can tell what their triggers are, we can talk about some different techniques that they're able to do to kind of calm themselves down. I don't have opposition towards medication. It's just I have found that more often than not, it is not what fixes the problem as much as I want it to.
Exactly. And remember, I caution about fixing versus managing, right? Because it's like, okay, let's get through the night, right? And yeah, but what am I going to do tomorrow? I said, let's get through the night, right? And you're absolutely right. All those variables, right? Like, what do we do? And depending on the relationship, the background, the expectation, what to do in the here and now. Parents need to go to work as well, right? And tends to be other siblings. So yes, it's not so simple and or complicated. And what are all these?
Stock up on melatonin and chamomile tea.
So these are all the things you look at, right? Absolutely, right? And so you start going, oh my gosh, is this really anxiety? And how bad? I would say how bad, right? Talking with the families, but how severe is it and how impairing? Well, certainly it's impairing that night, right? Are there any imminent risks or immediate risks? And then maybe not, right? But wait, do you focus on anxiety or do you focus on sleep? They may be different or they may be all related, right? What do the parents prefer, right? Certainly we feel pressured sometimes, right? Like you got to do something. What do you mean? If you don't prescribe something, we've heard this, right? If you don't prescribe something, you're not helping me. I have a script for that too, right? Well, if I truly don't think it's appropriate, right? Well, if that's the only way we can help, then we have an issue. So let's discuss it, right? Because let's talk about other ways. But being family centric, they look for something immediately. And then you're right. If you focus on sleep, all the literature supports short-term use of melatonin if you have that, right? If you focus on sleep. But in discussing with pediatricians and looking at the literature, could you call in a benzodiazepine? Well, there's not a lot of literature on 12-year-olds and benzodiazepines. Could it potentially help? Probably. Hydroxyzine or Vistaro gets used, right? And if you look at the FDA labeling, that's exactly what it is. And looking back and researching it, that doesn't seem to have changed in the last 30 years. And it's not related to kids, but could it be used? Maybe, right? And have family used Benadryl diphenhydramine? And yes, they have, right? As a sleep aid to help them, right? Would you use propranolol or clonidine? I would propose that there isn't a lot. And clonidine has a little bit of literature on it for sleep, but not anxiety, and certainly propranolol, not really in these kind of instances. So you make your decisions, right? And you make your decisions if there's something to kind of help the context of the situation, like take your pick, chamomile tea or melatonin, especially if you're saying, let's get you to sleep, even though it's not specific to anxiety, but it's specific to the symptom being presented at the moment. Now, for our South Florida folks, this is not unusual, right? Excuse me. Maybe in other parts of the state, it may not present as often, but these kind of things do happen, right? So keep that in mind, that we're talking, this presentation is focused on the maintenance. I'm looking at anxiety basically in the context of outpatient work, right? But there may be instances of whether this is a very cross-sectional anxiety-based reaction to the start of school and just getting over that hump and getting into the rhythm of things, or whether it's a signal for the onset of something else, or whether there's been the diathesis, right? These predisposing factors, and combined with this, etc. But just talk, but so you want to get through the moment, right? And then you work on the next phase of things, of what to do, where to go, and how to manage things. So I can't read the chat, but if there is anything in the chat, let me know or shout it out.
So Dr. Castellanos, there is a question in the chat. Any tip on weaning off the meds at the end of the recommended therapy period? Any withdrawal to look for that might mimic a recurrence, or just plain that are just withdrawal?
Yeah, so again, depending on several factors, right? Especially for an individual that has been on it quite a long time because of comorbidities, you want to go super slow on that discontinuation, and that at each step of that way, you want to keep reassessing and making a determination if there are emergence of symptoms, if they're medication related, like if you go too quickly, you can have these kind of dyskinesias, right? These kind of motor symptoms that make you look more restless and or anxious, and they're not technically anxiety. They look kind of like it, but very clearly, if you're starting to wean off and there's a re-emergence of those anxiety-based symptoms again, it really merits a reevaluation, whether you need to maintain them and or increase the dose again. Then it really means reevaluation, right? Because once you increase the dose, it's unclear when you look at the best practices and the evidence as how long you're going to maintain them at that dose again. So be careful for weaning off too quickly because of all the typical kind of discontinuation symptoms, whether they're motor, whether they're restlessness, whether they're, you hear with some of the other ones, like these cognitive things like zapping in the brain and electricity and other things like that. So keep that in mind, please. But a good question, very good question. Mirtazapine in adolescents, there is no literature on that, so you're in the weeds. So you decide what for, and there isn't a lot of literature on mirtazapine for anxiety, and even for sleep, right? When you review it for insomnia, especially for early or initial insomnia in teens, there is no literature on that. So you want to extrapolate from adult work and bring it down, maybe, but there is no real literature on mirtazapine and anxiety disorders in teens. And it's you saw those decision trees, right? You go sertraline, fluoxetine, then if you're going to move on, it's duloxetine, and then fluvoxamine, formerly or sold as Luvox, right? And then after that, you're really in what we call the weeds and judgments and like what you're going to do and what you're going to treat. So could it be, if you're down at that level, to decide that, maybe. Well, on that note, any other questions, right? Is it beneficial to refer to CBT from the start? Yes, it is, especially if you can find someone that performs CBT. Absolutely, it is. And remember, I'm not trivializing that. I mentioned that at the beginning. It wouldn't be the focus of this presentation, but absolutely, and especially for older adolescents, and hopefully ones that are engaged, who are motivated. CBT would be great, right? To learn those tools. And remember, CBTs work, right? It's like, I always joke, it's like losing weight, right? You have to be engaged and motivated, and but if you engage, boy, it can be really beneficial. Yes.
So thank you for saying that. On that note, and I know we're out of time in a minute, but I think everybody on the call probably knows that cognitive behavioral based interventions for panic disorder are extremely effective. They have some of the highest efficacy of kind of anything we know of in psychiatry, and can be done in a very brief number of sessions. There's even a 1-session CBT for panic. And I mean, we've seen kids Baker acted for panic. I mean, so it's just kind of unfortunate that it's not disseminated better in terms of how to use CBT to treat panic. What I don't know is, and pediatricians can absolutely do this. What I don't know is if they can bill for it.
Yes, for that one session intervention. So vis-a-vis the protocol. Okay, there you go. Well, I saw one head shaking. Yeah, so that's a disclaimer. We're not your billing agents, but if you can, you may want to look at incorporating that in your protocols, right? That's a really effective way of kind of moving that dial.
Thank you.
Well, thank you, Dr. Castellanos. This was very informative, and we certainly appreciate the time you spend with us. So thank you again.
Thank you for the opportunity, and we wish everybody to have a safe and productive week. Thank you.
Take care.
Thank
Bye-bye,
you.
everyone.
Thanks.
Thanks.
Bye.